Okay, we've heard from three of the experts, but everybody in this room is an expert one way or another, personally, professionally, or some other capacity. So if what I'd like to ask you, you've all heard this. Now we're going to come out of this conference and hopefully we're going to get together and do something. So if you could wave a magic wand or set the agenda and say, if we were to do one thing together as a group post this conference, what would it be? And if you really want to, you can have two, but if you could do two things, what would it be? So come up, if you will, and maybe I will start just to get the ball rolling. One is, I think we really have to tie this issue to the things that really matter. And I think Charlotte talked about the one that matters to people, which is fundamentally the quality of their lives in a compelling way. But I think the one that matters to policymakers is not healthcare cost, it's economic, it's contribution. To the extent that people with hearing loss are really not working or working fewer years, or if it's 2 years less on average, they're not volunteering, they're not helping in their families, that to me has a higher probability of being a persuasive case. So one of my wishes would be that we really try to look and figure out if we can draw that connection in a way that I think would attract policymakers. My second insight is that if 40% of people over the age of 65 and 70% of people over age 85, we need to address this through universal design. There's no point in saying everybody in this room has a hearing problem. We got to give everyone, if you're a hearing aid, we got to have a loop. We have to have technologies here. We have to realize if you're talking about population, senior centers, retirement communities, where the majority of people have an issue, we need to do things like we've done on closed captioning for TV. We need to address this as a large public and take advantage of public health universal design solutions. One that I noticed, I went to an animated cartoon last week, and I swear I could read the lips of the cartoon characters. Somebody figured out how to do that through technology. So those are my two. But what are yours? We want to hear from as many of you as possible in the next 20 minutes. And if people agree, let us know, because we want to try to get a sense of whether there's some consensus. If I could wave my magic wand, we would. That's the...
Hi, everyone. My name is Wen Chen. I come from National Institute on Aging, which is part of the NIH as well, and we support research. The mission of NIA is to support research and the public communication related to healthy aging in older adults. And within my program, we have a portfolio on audition, and we do support research specifically related to age-related hearing loss. And so a lot of issues that were discussed in the past 2 days are certainly of high importance to us. After hearing a lot of issues that have been discussed, one thing that resonated with me through my experience working at NIA is that we could do better in terms of communication about the message to the general older adult community, especially related to hearing loss and what kind of devices and hearing aids that would be helpful for them. It's really astounding to see the many choices that are available to older adults, but it's really unclear to me which ones are really good for what kind of older adults with what kind of hearing loss. And I wonder if whether those are the things we could get better clarification on in terms of communicating message. And also, there's some terminology that could be confusing to people that are not audiologists or hearing experts. For instance, telecoil. You know, I think most people probably wouldn't know what it is, and however, or the loop, but if we put it in terms of noise cancellation device, that may be very helpful, because almost everybody I heard, you know, in terms of complaining about their hearing in the older adult population, is I can't hear in a noisy environment. I mean, that's the #1 issue for them. hearing aids, does that help me? I want something that will cancel all the noise so I can hear what I want to hear. So maybe, I mean, there are devices available for them, but I think the terms of those devices not very intuitive for them to think about. Those are things they should be asking for. Certainly, as a research funding agency, we are more than willing to partner with all the relevant organizations to advance this area of research, and I just wanted to make that message.
Great. So I hear you suggest collective action around communication, changing the conversation and awareness, both at the problem and the solution?
Actually, that's one, hopefully, and we will, I know within NIA we have Office of Public Communication, and I certainly will be going back home and work with them about how to enhance this area of communication, and I'm sort of open to hear all your recommendations. We're part of the sponsors for this workshop, so certainly we are very interested to hear the outcomes of the workshop at the end. But I wanted to also bring up the awareness from our institute on this topic, and wanted to make that clear to everybody as well.
Thank you very much. Good. We want to try to get as many ideas out as possible. James.
Good afternoon. James Appleby with the Gerontological Society of America. Picking up on those comments, the two areas that I'd suggest we collectively try and get after is, one comes down to the research base, generating the research necessary to demonstrate that this intervention has value not only in improving health outcomes and perhaps turning around the trajectory of some patients' lives, but also getting at the impact, Jim, to what you were saying about the economic benefit of this activity in terms of how it changes, in particular with older adults, how they engage and what the impact is down the line. Then the second place gets back to stigma, and I was very encouraged by the results, Charlotte, you reported about the survey of AARP members, and I really want to believe that data, but it's so much flies in the face of what we see day in and day out. But it does encourage me that perhaps we can make efforts to try and as you say, change the conversation or reframe the conversation. I mean, they've done this in the area of smoking cessation to get smokers to sort of rethink about, well, I want to be around for my grandchildren, so let's think about it. I think perhaps we can look at that reframing process and figure out how to change the conversation so that indeed people aren't afraid to talk about it and they're willing to engage and try to basically take proactive steps to change their own issues around hearing loss.
Thank you. Yeah, James, there is an emerging art and science of reframing conversations that might be very relevant for this issue. Yes.
I'd support that. Anna Gilmore Hall, Hearing Loss Association of America. Talking about living successfully with hearing loss is really what I think is an outcome of these 2 days. Not only can I live successfully with hearing loss and stay young and stay sexy and stay relevant and staying in the workforce, that's the kind of message I think all of us coming out of this conference should start talking about in terms of reframing the conversation, as well as the fact that there are many ways to live successfully with hearing loss, including some of the technology options that we've talked about. So I think coming together around those two things would be really, really helpful.
Terrific.
I guess my first wish would be that basically that hearing health care would be an essential health benefit. And the secondary one would be for the FDA to push a little harder in the honesty in advertisement. The only disruptive innovation I know of noise reduction in hearing aids is creative microphone strategies. And yet we're inundated with the improvement in signal-to-noise ratio in artificial environments that don't really help the patient.
Great, thank you. Yeah.
I think the major issue, the first major issue that would be helpful to come out of this conference is something that you talked about, which is namely the affordability issue. And that requires basically, one of the things that's important here is that it requires some sort of dramatic change to the FDA rules. Now, the FDA rules, unfortunately, there is a tremendous amount of players involved in this, and there is a way to change these rules so it works out for win-win both for consumers and for companies, both hearing aid companies, PSAP manufacturers, and everything else. There is a way to do it, but it's going to be very difficult. And one thing that I would like to see come out of this conference is some sort of other kind of meeting which would focus specifically on these rules that would empower all these companies and all these players to be able to make an affordable solution. The second thing that I think would be helpful is what's very striking, and it's a conversation that I also had with Dr. Lin privately as well. But it's very striking that all the that hearing loss, despite the fact that everybody we know has been impacted negatively by hearing loss, because even if we don't have it ourselves, we have relatives who have it, that it isn't higher up on the agenda of gerontology, epidemiology, et cetera. A crass way of looking at that is we got a marketing problem, folks, and a more sophisticated way of looking at it is somehow or another thing that should, I think, come out of this conference is some sort of way of raising the profile of how serious this condition is and how central it is to our lives, not only in the notion of quality of life, but also in a larger notion, in many larger notions as well.
Great, thank you. Barb.
Okay. I would like to see us reframe the focus of the hearing healthcare delivery system with the patient at the center of the audiologic assessment. I think audiologists have to remember that people are coming to them because they have difficulties in certain areas, and they must leave your office with solutions so that if a person may not, on the readiness continuum, a person may not be ready for a $6,000 hearing aids, but they may only have problems with the telephone. Give them a device or suggestions for the television. Maybe they do need a personal sound amplifier. We have to work with the policy people to, work that in too. We have to make sure audiologists listen to the patient. Patient is coming in for a solution. They must leave with a solution.
Thank you.
My feeling is a little bit like what Richard said. We need to engage the hearing population as well as the hearing loss population. I think they need to understand that this is, if not a universal problem, close to it. And part of that, I think, is making hearing aids, as I said in my talk yesterday, as affordable and as ubiquitous and as effective as wearing glasses. So this massive technology that we're all dealing with just needs to come down to make something that will allow us to hear it, that will allow us to go out and be normal people in the world like everybody else, just like the people wearing glasses. It's because it's all so complicated that I think a lot of us feel that we have an unusual and embarrassing condition that we need to keep to ourselves.
Thank you. Yes.
Hi, my name is Stephen Barnett. I'm at the University of Rochester. I'm a family physician and I do community participatory research. So two things that I didn't hear clearly during the 2 days that I would like to be part of the conversation. The first, I thank a colleague, Mary Chiswick, Chizuk. She asked me this question that she had asked her doctor. Now that I have hearing loss, what are the other conditions I need to be concerned about? And although there's some cross-sectional studies that suggest association, my answer to her was the same as her doctor's, which was, I don't know. And they could be things that you have to worry less about, like do we change screening? Are you at lower risk for certain things? So those things haven't been studied. And then the related thing I didn't hear a lot about is surveillance that's more meaningful for making decisions. So the standard HHS, Health and Human Services questions on hearing loss aren't helpful. The NIDCD questions get at a lot more meaningful information to help understand the data. But the one piece I haven't seen, and I haven't spoken with Howard about the recent questions, I haven't seen since 1991 is the duration. And whether it's a cognitive load issue or duration with stress issue or opportunity to adjust issue, I think knowing how long someone has had their hearing loss will help us to understand the health data. So surveillance and broader look at healthy aging with hearing loss.
Great, thank you. Yes.
I have to preface this by saying I've been married to a wonderful man for 25 years who doesn't wear his hearing aids as often as he should. And my colleague in the audience will laugh if he hears that story again because he saw that clearly one day. But a couple of weeks ago, my husband and I were watching television and an ad came on for a woman was talking about her asthma. And she's sitting in the couch in her living room. And if anyone's seen this, Twinkle, that's what that's called, she talks about how her asthma does not affect her life, okay? Doesn't really have that much of an impact. And all of a sudden they show her husband walking in the room. And he makes a comment about, honey, don't you remember the trip we had to stop, we had to go to the ER? Each of her children walk in the room. Mom, this really scares me when you can't breathe right. Her boss is shown coming into the room. You know what, Charlotte, you missed a couple of meetings last month. All of a sudden, these other characters come in. You have to be careful not to be punitive when you're sending that message. But my husband turned to me and said, wow, that's kind of like what you tell me about my hearing loss. And it was the aha moment. Yes, this is what I have been trying to tell you. You've misunderstood. I have well, they're not teenagers anymore, but you talk about some miscommunication and mishearing your 18-year-old son. That's not a good thing sometimes. He terribly misinterpreted some conversations. So somehow getting that message that it's not just you that's affected when you have a hearing loss, your community is affected. If we could have a somehow unbiased messaging on that, it would be very helpful.
If my wife were here, she'd be volunteering to be in the commercial, so thank you. Yes.
First, thank you for the wise recommendation on universal design. I actually, Valerie Fletcher from the Institute for Human-Centered Design, a really simple suggestion, as probably the person who knows least about your expertise across the room, I have heard more vignettes of success in the last 2 days than I've ever heard before. And in many cases, they are about a collaborative effort with the patient and the clinician and people who understand the technology. And they're great stories. They're very brief stories. But one organization that carried 100 stories or 200 stories of very distinct individual profiles and what works would go a long way towards eradicating the assumption that nothing works very well. Thanks.
Well, I echo a lot of what other people have said, but I say a couple of things. One is when we think about an educational approach, which I think is critical to inform and increase awareness, I think we have to build into that, because we know hearing loss is across the life spectrum, a true focus also on prevention and looking at the strong value to noise in our environment now, where environments are actually built to be noisier. And I think that's a critical problem in general. I also think we need, in that awareness, to build it into curricula types of things where, for instance, one of the things when we talk about universal design, there are many ways that we can build facilities that are hearing friendly, and we don't tend to do that. And so unless you take into account maybe looping or putting in the induction loop when you're building it, so you don't have to worry about it after fact or thinking about the acoustical design, I don't think people in the architecture field get that in terms of information. And finally, in terms of looking at workforce, I do really think we need to look at interprofessional kinds of activities and changing the roles and responsibilities and who can do what in the best way.
Great, thank you. There's some, yes. Try to get through everybody, so let's.
My name's Alicia Spohr. I'm here with the Academy of Doctors of Audiology, but being a healthcare professional who works with some of Dr. Lynn's colleagues down in the area, and knowing that our long-term goals of this summit are going to be long-term goals, I would like to put a plug in for a short-term recommendation goal in the fact that I feel like we're all on the same page in the terms that we want to help people and we want to do the best we can and we want to get to that end state. But in the short term, I'd like to see us communicate with those general practitioners a little bit more so that they know what they're asking for about hearing. Just like I know that I should be asking my patients, are you smoking? And if you are, you should go see your doctor because you should stop. Just having a quick sentence or a quick plug to say, how's your hearing? And if the patient goes, well, at least you can say, here's a name or here's a website or here's something you can do about it.
That'd be great. Although I would say a doctor asking a patient how you're hearing is not a very reliable test. Yes.
Chris Roberts, Cochlear. I would like to come back to the theme of the workshop, which is hearing loss and healthy aging. And my one wish is that we succeed in creating a disconnect between chronologic aging and our biologic aging. There's been a fundamental assumption here that we'll wait till the biology or that the biology will go wrong and we'll go in and do something about it. I'm a bit disappointed we haven't spent a bit more time on what we can do to slow up that biologic aging, both in the periphery and centrally. And perhaps we touched on it a little bit, but what are we doing about noise exposure, for example, as we get older? What are we doing about, if people just slowly turn up their television, are they not training their brain to just listen to louder and louder talking? If we just sort of sit in our room and read as we get older versus sitting in our room listening to an audio book and listening to an audio book at maybe 20 or 30% the speed of normal conversation, and you do that for the next 10 years of your life, what are you doing to train your brain much more, for example? I think there's a lot more that we could do to affect the biology of what's happening and not just assume that it's all going wrong. So my one wish is a better disconnect between chronologic aging and biologic aging.
Thank you. Is that clock is accurate? Yeah. Okay. So nobody else can get up. We'll take the last 5 great ideas and then we'll turn it over. Yes.
Brenda retired. A couple of things. One is I understand from ARP survey that most baby boomers want to stay in their homes as they grow older. And you cannot stay safely in your home if you don't address your hearing loss. So I think that message has to get out because it helps the healthcare costs, it helps the wishes of the person, and it certainly helps the wishes of the family. So that's a strong message that we need to be sending. Secondly, I totally agree with Richard. The FDA regulations, as far as I'm concerned, are out of date. They're not in touch with what's going on in the world today. Neither technologically nor societally. And I think that we need to get a group together and we need to hit that issue head on very strongly. And thirdly, I would like the hearing aid manufacturers to spend more time making sure that hearing aids work in noise and not selling us a lot of extra equipment to overcome the fact that they don't hear in noise.
Thank you.
I'd like to have more clarity on the association between hearing loss and broader outcomes like some of the psychosocial, functional, and physical. There's a lot of great research showing associations, but I think if we had more information on mechanisms and cause and effect relationships, and it would go a long ways in, first of all, as a physician, being able to counsel patients about their hearing loss, and secondly, as a public health professional, advocating for better funding and services for these people. And then the second thing that I'd like to see is better outcomes data on some of the solutions that we've talked about over the last couple of days. And I think that, again, would go quite a ways in terms of telling patients what might work for them and also advocating on a broader scale. Last thing, I think that it's important to advocate to find out who the at-risk populations are so that we can focus on these people.
Right.
Howard Hoffman, DCD. I rise in part just to answer partially Dr. Barnett's question. I didn't mean to leave the impression that we only collect data from NHIS and Haynes. for healthy people? No, we collect a much richer data set. And we do ask in these cross-sectional surveys how long they've had hearing loss. But I think that's just part of the answer. Really, what we would like to have would be longitudinal data. And there are some surveys that can accomplish that, and Karen Cruikshanks is smiling because she's been doing that for the last 2 decades, I think. Right. and that's very informative data. It's very difficult to do on a national level. We are trying it with children with the Department of Education in first grade or second grade and then third grade, testing their hearing. That's never been done in the U.S. So we are trying for children. There are some adult studies, and there are some panel surveys that maintain the panel and look year after year. So that could be very helpful for teasing this out. Of course, we all know the benefits of a clinical trial if it can be done. And that's always a big if, and if it can be done appropriately. So thank you.
Thank you.
Hi, Diane Nenz with High Health Innovations. First of all, I wanted to say awareness is a big passion of mine. I have been speaking for years on our topic, getting our message out there. But when Charlotte just spoke a few minutes ago, she really was talking about turning that positive. And I love that because I tend to think in the positive light. And I was thinking, what message, how are we being perceived as we are giving our message, as we are educating and raising that level of awareness? And we want to motivate and we want to make people feel good, but we also want to get our message out there as far as what are the solutions and how can they access the proper care. So I think our messaging is really important. Also, we've learned over the past couple of days, and we've known this, that there's many people that need hearing testing. So I'm really looking to see, and I'm hoping that more primary care physicians will go ahead and start testing patients. And finally, and this is probably my biggest hope, is that we see all the new delivery models and we see access. We've talked about affordability and learning the details of what affordability means, not just cost. Hoping that we can all work together in harmony because we know that there's not just one solution for all those patients that need help.
Thank you. Oh, 2 more. Okay.
I'm glad Sergio's over there now. I don't have to be the last one. So, Bill Dickinson with Phonak. And I guess while this stage in my life and my career, I'm representing what I believe is a very honorable and worthy manufacturer. First and foremost, I'm a clinical audiologist. And I'd like to say that I think in the 21 years that I've been fitting patients and running large academic medical center hearing aid programs and doing research and teaching students, this is one of the most proud moments I've been an audiologist in this room. And you look around and what makes this very special is the huge diversity that's in this room. And from medicine, primary care, otolaryngology, university research, clinical practice, private sector, public sector, industry, manufacturers, technology, devices, and all of that is what the common denominator between all of that is why we do what we do. The one thing that every one of us has in common in this room is that is the why we choose to get out of bed in the morning and do what we do. And the what is what often defines us. And so I hope when we all walk out of the room that we don't fall back into breaking apart and being driven by the what, and that we keep that common bond of why. That's what I would like.
Thank you. Well said. Yes.
I think I could have sat down for the last 2, but I just wanted to share that the idea of, of identification of hearing loss. And I find it difficult to believe that in primary care offices that it's okay, you can write a script for I need to have your CBCs done and do all your stuff, and I want you to have a colonoscopy and I want you to have everything else. So I understand that time is important for people who are seeing a lot of patients today. But in our institution, University of Miami, we've actually inputted with our new EMR system that when we're looking at the age factor, that certain flags show up. So all our primary cares, they say, how's your hearing? Oh, it's okay. No, how is your hearing? So they do have, like I've said, they do have a slight screener, but if they fail, they automatically put that in their referral base. So it automatically flags for audiology. And those patients are seen, are identified. And we'd like to see that go throughout, where hearing healthcare becomes part of standard care throughout for everyone. And you can, create an age, you can do whatever you want. They say after the age of 50, you're supposed to have, certain tests done. Well, I think that we should do that for hearing, because we keep hearing how it affects our life and how, and Charlotte, thank you, you're 100% correct. Everything that is done, everything negative that hearing does, but now we turn it into a positive because we are going to identify their loss, help them, and hopefully turn everything that was originally, a negative and affected their life in a negative way, we actually improve it. So there's a positive. And the last comment is regarding the FDA. I think we need to look at the outdated measurements for cochlear implant candidacy. Since the EAS with MED-EL came out, I've got two people who will sit there on the highest tower and scream out, hearing aids didn't work for me, the implant did. They would not have fallen under the regular, the regular CI, but are now the most happiest people in the world. So I think we need to look at what we're doing out there.
All right. Well, thank you. And let me just say one last comment before I turn it over to the co-chairs. So we come here together. We do have, as was eloquently stated, have a shared sense of urgency that there's an issue, there's a problem that matters, and I'm sure you wouldn't have been here for 2 days if you weren't really committed to doing something about it. We've identified real areas of work in terms of changing the conversation and awareness, more research, training and education of professionals, policy and regulatory issues, new technologies, both for the individual level and the universal design level. But one thing I know is the reason that this conference happened was because we not only had leadership, but we had backbone support. The IOM staff organized and put together this meeting and made it possible. If any collective action, if it's going to move, if we are going to move together, we're going to have to solve for the issue of whose day job is it to provide backbone support to collective impact. So I believe there is an opportunity for collective impact, and that surely the things we're talking about we can much better do together than our own, but there is this hole to solve for about who would provide the support for us to continue to collaborate strategically on this issue. So thank you. A round of applause for our speakers.